Hey guys, welcome back to Vids Made Simple. In this video we're going to see about cephalosporins. Now let's begin. Before watching this video, please subscribe to our channel Vids Made Simple and press the bell icon nearby to get notified as soon as we upload our videos. And support us by donating on Patreon to help us make more videos. Cephalosporins belongs to a group known as beta-lactam antibiotics. I've already made a video on introduction of beta-lactam antibiotics and on penicillins. I provided the link in the description of this video. Click it and watch it. So, about the structure of cephalosporins. The structure of cephalosporins is almost similar to that of penicillins. But however, the nucleus of cephalosporins is different. The nucleus of cephalosporins consists of 7-amino cephalosporinic acid. But in penicillins, it is 6-amino penicillinic acid. The mechanism of action of cephalosporins is similar to penicillins. They act on penicillin binding proteins, which are abbreviated as PBPs, and by doing so they inhibit cell wall synthesis of the bacteria and they kill the bacteria. That's why they are called as bactericidal. So basically the cephalosporins are classified under 5 groups or 5 generations. The first generation includes drugs such as cephalexin and cefazolin. Second generation includes drugs such as cefuroxime and cefoxitin. Third generation includes drugs such as ceftriaxone, cefoperazone. Fourth generation includes drugs such as cefepime. And fifth generation includes drugs such as ceftaroline. Now don't get panicked and don't worry that you got to remember this exhaustive list. And I've just made it simplified and I've just put the important drugs in this list. There is even much more exhaustive list beyond this. It's adequate if you can remember these drugs in the first place. Then you can slowly build up one by one, and you can remember further drugs. But you must know all these drugs, and these are must know. So let's see about the individual generation and drugs one by one. First generation cephalosporins are active against gram-positive cocci such as Staph aureus, Streptococcus pneumoniae, and they're also active against, they have some kind of activity against Escherichia coli, Klebsiella pneumoniae, Proteus mirabilis, and they are also active against few anaerobes such as Peptococcus, Peptostreptococcus, etc. So they have very low gram-negative activity. The thing which you need to remember is the gram-negative activity will increase from the next to next generation. That is, the first generation will have less, or let's take it this way. The second generation cephalosporins will have much of gram-negative activity compared to first generation cephalosporins. Third generation will have much of activity than second gen, and it goes like that. So the drugs which are taken orally in first generation cephalosporins includes cephalexin, and the drugs which are taken intravenously or parenterally is cefazolin. It's not the point that cefazolin can also be taken intramuscularly. Pharmacokinetics part of first gen cephalosporins is that they penetrate well into most of the tissues in the body, so they have better actions all over the body. But you gotta know the fact that they do not penetrate the blood-brain barrier, so they cannot be given to treat meningitis. So you gotta remember this. The excretion part, this is almost similar in all the cephalosporins. They are excreted by kidneys mainly by glomerular filtration. They are also excreted by tubular secretion. A few part is excreted by tubular secretion, but it's mainly by glomerular filtration. So you gotta know the fact that dose reduction is required in patients who have renal disease or kidney disease. So if you don't reduce the dose of cephalosporins in these patients, obviously they're going to develop toxicity and it's going to worse their problems. Okay, so you have to reduce the dose of cephalosporins in renal disease patients. So there's a drug known as probenecid which can increase the serum levels of cephalosporins when they're given together. So this probenecid will compete with cephalosporins to be excreted in urine, and so that's why they'll increase the serum levels of cephalosporins in the body, and that can increase toxicity. However, if you want to prolong the action of cephalosporins in the body, you can obviously combine probenecid to it. So the main uses of first-gen cephalosporins include The oral drugs such as cephalexin can be given in mild conditions such as urinary tract infections, and they can also be given in conditions such as cellulitis and soft tissue abscesses. However, there are better drugs available compared to cephalexin because cephalexin have many bacteria have developed resistance to cephalexin, so there are better drugs available, so they have replaced cephalexin for these purposes. Intravenously given cefazolin also has many uses, but the main use you gotta remember, and they gonna ask you this for sure, is that the cefazolin is the drug of choice for surgical prophylaxis. So before they operate a patient, so before you perform any surgery, you gotta give an antibiotic as a prophylaxis to prevent any infections following the surgery. So the drug of choice for that is cefazolin, and you gotta remember this fact. Cefazolin is the drug of choice for surgical prophylaxis, and it is given intravenously. Now let's see about the second generation cephalosporins. The second generation cephalosporins are active against all the bacteria which were inhibited by the first generation drugs. So we've seen a list of bacteria which were inhibited by the first generation cephalosporins. So second generation cephalosporins also has activity against those bacteria, and they have better gram-negative coverage compared to the first generation cephalosporins, as I have told you earlier. So second generation cephalosporins more effectively inhibit gram-negative bacteria compared to first generation cephalosporins. And you got to know the fact that they also act on Klebsiella, so they can be used to treat Klebsiella pneumoniae. And the drugs in this group includes oral drugs such as cefuroxime and parenteral or intravenous drugs such as cefoxitin. So here you got to know the fact that this cefoxitin, which is mentioned here, which is given intravenously, cannot be given intramuscularly. Okay, so if you give this second generation drugs intramuscularly, it can cause severe pain due to irritation. So about the pharmacokinetics, they also penetrate well into most tissues, but they do not effectively cross blood-brain barrier. It's the same as the first generation cephalosporins. So as they do not cross the blood-brain barrier, they can all be used to treat meningitis. They are excreted by kidneys as well, so as I mentioned earlier, dose reduction is required in renal patients, or else the toxicity is increased. Main uses of second generation cephalosporins include the oral drugs can be used to treat conditions such as sinusitis, otitis, which is the infection of the ear, or lower respiratory tract infections, and intravenous drugs can be used to treat the infection. Intravenous antibiotics can be used to treat infections caused by anaerobes. So most commonly the infections such as peritonitis, pelvic inflammatory disease, and other conditions such as diverticulitis. So these are the main uses of second generation cephalosporins. Now see about third generation cephalosporins. Now these cephalosporins have even much better activity against gram-negative bacteria compared to the second generation cephalosporins. So as I've told you earlier, the gram-negative coverage will increase from generation to generation in cephalosporins. Okay, so they also have activity against Citrobacter and Providencia. The drugs which are given orally in third generation cephalosporins include cefixime. The intravenous drugs include ceftriaxone. This is very easy to remember. See, the word ceftriaxone has a tri in it, tri, so it's a third generation, tri. Okay, so ceftriaxone is a third generation cephalosporin. So the pharmacokinetic part, you can see that I highlighted this point in green, so that really means that it's very important, super important to remember. So they also penetrate well into many tissues like the first and second generation drugs, but the very important differentiating feature is that they can cross the blood-brain barrier, and that basically tells you that they can be used in the treatment of meningitis. Okay, so since they can cross the blood-brain barrier, they can be used to treat meningitis, which is caused by many bacteria such as Haemophilus influenza, or Neisseria meningitis, or pneumococci, etc. Almost all the members of these third generation cephalosporins are excreted by kidneys, like the first and second generation cephalosporins. However, there are two exceptions in this group, which includes cephalosporin and ceftriaxone. So these are mainly excreted through the biliary tract. So if you are going to give these two drugs to a patient with renal failure or any renal disease, dose adjustment may not be required so much. But if you're going to give any other drugs in this group to a patient with renal failure, you obviously going to reduce the dose, okay, to avoid toxicity. So the uses of third generation cephalosporins is that the main use is can be used to treat meningitis. So ceftriaxone is the preferred drug. So the dose is 2 grams and it's given 12 hourly, so almost twice daily. And the third generation drugs can also be used to treat various severe infections. Okay, so they are preferred to treat various several infections. But the fact is that they need to be given intravenously. Okay, so ceftriaxone, which is an intravenous drug. So these drugs are the third generation cephalosporins are also preferred in treatment of sepsis by various bacteria, and a condition known as gonococcal urethritis, which is inflammation of the urethra caused by Neisseria gonorrhea, can also be treated with a third generation cephalosporin such as ceftriaxone in combination with any other drug, any other antibiotic. Now let's see about the fourth generation cephalosporins. So they are active against many bacteria which were mentioned earlier, which were inhibited by the previous generation cephalosporins. In addition, they are also active against bacteria such as Pseudomonas aeruginosa, Enterobacteriaceae, Staphylococcus aureus, Streptococcus pneumoniae, Haemophilus, etc. So the very important drug which you need to know in this generation is cefepime, which is given intravenously. So it's a parenteral drug. They also have the similar pharmacokinetic feature as third gen cephalosporin, that is, they penetrate into most of the tissues in the body, and they also penetrate blood-brain barriers, so they can be used in the treatment of meningitis. They're also excreted by kidneys. So it's very easy to remember the pharmacokinetics part of the cephalosporins, so you need not confuse between various generations in cephalosporins. Almost all the members in the cephalosporins are excreted by kidneys except for two drugs in third generation cephalosporins. So make a note of that and try to remember that. The uses of fourth generation cephalosporins include they can be used to treat meningitis, and they can also be used to treat Pseudomonas aeruginosa infections. So they can be used to treat meningitis because they can effectively cross blood-brain barrier, and the treatment of Pseudomonas aeruginosa. So this is very important. Pseudomonas aeruginosa cannot be treated very easily, so this requires a really effective drug. So if you're gonna choose a drug, the fourth generation cephalosporin obviously remains as a choice. Cefepime remains a choice for treatment of fourth generation cephalosporin. So let's see about the fifth generation or the last generation cephalosporin. They are active against MRSA, which is methicillin resistant Staphylococcus aureus. The very interesting fact which you need to know is that the methicillin resistant Staphylococcus aureus is not inhibited by any penicillins or any other cephalosporins which we've been talking about from the first, such as the first generation to fourth generation. None of the cephalosporins can inhibit or kill the methicillin resistant Staphylococcus aureus except for the fifth generation cephalosporins. So if they're gonna ask you a question stating that which cephalosporin can really kill methicillin resistant Staph aureus, it's obviously a fifth generation cephalosporin such as ceftaroline. So it's very important to remember that no other cephalosporins are really active against methicillin resistant Staphylococcus aureus. It's only this ceftaroline or the fifth generation cephalosporins which are really active against methicillin resistant Staph aureus. So they also have broad spectrum gram-negative activity that they can be used to treat various gram-negative bacterial infections. So the main uses of fifth generation cephalosporins are in the treatment of skin and soft tissue infections, community-acquired pneumonia, and as I told, they can be used in the treatment of methicillin-resistant Staph aureus infections. Now let's see about the adverse drug reactions of all the cephalosporins. Now I've tried and put all the adverse drug reactions of the cephalosporins in one slide. So the commonest thing which we need to worry about regarding the adverse effects of cephalosporins or penicillins, both they have a considerable amount of incidence of allergy. So the features include skin rashes, fever, anaphylaxis, nephritis, granulocytopenia, hemolytic anemia. So you gotta know the fact that cephalosporins are somewhat nephrotoxic, so they can cause renal toxicity if not given in adequate dose, if not given in a proper controlled manner. So if you're gonna give overdose of cephalosporins, it can cause renal toxicity. And they can also cause irritation, so they have irritative effects. If you try to inject them intramuscularly, it can cause severe pain, and if you inject them intravenously, there are chances of developing thrombophlebitis. So as I told you earlier, cephalosporins can cause renal toxicity, so they are somewhat nephrotoxic drugs. So the main features include interstitial nephritis and tubular necrosis. So you need to be cautious about using cephalosporins in renal patients or kidney disease patients. So a few drugs in cephalosporins can cause hypoprothrombinemia, which will lead to bleeding disorders, and they can also cause disulfiram-like reactions if they are taken following alcohol intake. So what's this disulfiram-like reactions? So disulfiram is actually a drug which is used in alcohol de-addiction. If a patient takes disulfiram and he tries to consume alcohol, what happens is the alcohol cannot be metabolized in the body and it will get converted into aldehyde, which is not good for the body. So he will start to develop various manifestations which will not be tolerated by the patient. So he'll start to develop aversion towards alcohol. That's the main intention, but however that can be somewhat not so good for the patient. So here, following consumption of alcohol with few of the cephalosporins such as cefotetan or cefoperazone, what happens is the same disulfiram-like reactions can happen. So it's advised, so the patient should be advised that they should not take alcohol following taking these drugs. So that's the thing which you need to make a note on. So a few common facts for all the cephalosporins is that don't use any cephalosporin for treating Enterobacter infections. So try to avoid it as much as possible. I'll tell you why. It's because Enterobacter, it's not that Enterobacter is totally resistant to cephalosporins. It's that some are sensitive to cephalosporins. But when you start treating them with cephalosporins, what happens is only the sensitive bacteria will die, and all the resistant bacteria which are not inhibited by cephalosporins, they selectively start to grow, and the treatment of that bacteria will become very difficult. So that's why you should try to avoid using cephalosporins in treating Enterobacter infections. Second thing is that all cephalosporins are inactivated by AMP-C and extended spectrum beta-lactamases. So these are the enzymes which are secreted by the bacteria for their own protection against the beta-lactam antibiotics. So these, if a bacteria is going to produce these two enzymes, so they are definitely going to break down the cephalosporins, and they are protected against cephalosporins. So the cephalosporins are not active against the bacteria which produce AMP-C and extended spectrum beta-lactamases. There is about 1% cross allergy between penicillins and cephalosporins, which means if a patient is allergic to penicillins and if there is a previous history of penicillin hypersensitivity reactions, there is about 1% risk of the same patient having the same adverse reactions to cephalosporins. Hope you like this video. Please support us by donating us through patreon.com/medvids made simple. And we'd like to thank our major contributor Beirut M, who has donated $80 to us. Thank you, Beirut M. Subscribe to our channel Medvids Made Simple and share this video to your friends. Follow us on Facebook and Instagram by clicking on the links given in the description below. And stay tuned for more videos. Thank you.